And now I'd invite Dr. Jyoti Prakash Vyas for his talk on 10 pearls in the diagnosis and management of central serous chorioretinopathy. Jyoti is a consultant vitreoretinal surgeon at Giridhar Eye Institute, Cochin. Over to you, Jyoti.
Thank you, sir. I thank KSOS and the scientific committee for giving me this opportunity. So I'll be taking the topic on pearls in the management of CSCR. I've deliberately omitted the number 10 because I don't know whether I'll be able to cook up 10 pearls actually or not. So coming to the rough introduction onto the CSR, it's a localized serous detachment of the posterior pole, which are focal detachments of the RPE, with usually seen in two clinical forms like acute and chronic. Acute, by definition, is of less than 3 to 4 months of duration, and anything more than that is variably called chronic CSR. The chronic CSR has a specific entity when it is seen in patients above the age of 50 years, and it often resembles CNVM or ARMD, and it is often complicated by a similar picture. It has a higher prevalence in males, about 6 times more in women, 6 times more than women, and the age of presentation is usually 39 to 51. With the advent of OCTA in clinical practice since 2014, it has helped to visualize specific patterns of CSCR and the management therefore. OCTA changes in CSCR which are usually seen are hyperperfusion and flow voids, and also new networks which are seen in some ambiguous cases. The main goal of treatment in a CSR case is actually going to be complete and durable resolution of SRF and improvement of the visual acuity. Looking at the science, what we have understood over a period of time, the first thing which came out was in 2016 when Wong et al. Had put forward a few of the parameters which we usually look in the history as well as the management protocols, which are based on the available level of evidence. They are defined the evidence as good, fair and poor according to the standard definitions. So in the risk factor modification, the quality of evidence was extremely good for glucocorticoid discontinuation. So if you discontinue glucocorticoids, an improvement in CSR is definitely seen, whereas pregnancy and delivery and phosphodiesterase inhibitor withdrawal had only a moderate amount of, or you can say a fair amount of evidence that they really worked in this treatment. As opposed to diabetic retinopathy, obstructive sleep apnea does not actually have a significant effect in management of CSCR. The treatment modalities which have been there for quite many years, only PDT and focal laser have a good quality of evidence. Anti-VEGF and sub-threshold micropulse only stand at a fair chance of quality of evidence, whereas the much fabled mineralocorticoid receptor antagonists do not enjoy that level of evidence. The treatment options were initially based on the finding of choroidal abnormalities on ICGA and also on FFA, but ICGA definitely showed a significantly high amount of changes as opposed to FFA. So treating the choroid with PDT based on the choroidal findings on an ICGA happened to be the best treatment available. In acute CSR, the treatment paradigms which are used right now is, which has been followed for many years together, is observation for an initial period of 3 to 4 months and waiting for spontaneous resolution. After 3 months, if the OCT does not show any resolution of SRF or if there is a residual amount of fluid, we subject the patient to an fluorescein angiography and an ICG. And in case of an active leak, this can be treated. If it is a subfoveal leak, a PDT can be done even in an acute CSR, and if it is an extrafoveal one, probably a focal laser to the leak can be done. This is just to show post-focal laser how the CSR tends to resolve and a normal foveal contour is achieved. About 15 to 50% of patients of acute CSCR who are not treated actually tend to have more than one recurrence over a period of 1 year. And they say at some point of time in a conjecture, they come to the point that in acute CSCR, PDT can be used when the fluid is persistent for more than 3 months. According to Oskaya and Mohabbati, they also showed that post PDT, the number of recurrences also reduced from a 24% in the untreated state to 4% when treated with PDT. In chronic CSCR, Januzzi had initially postulated this way back in 2000 that based on ICG abnormalities, treating with PDT led to a significant improvement in the clinical condition of the patients. And since the SRF is a waxing and waning pattern seen in this disease, they actually followed that treatment only. Until that time, about 2018, there was no randomized controlled trial which actually looked into the various other treatment modalities for this disease. Following the PLACE trial, they found out that PDT is better than subthreshold micropulse laser. The improvement chances improve from 67% in PDT, whereas it's only about a meager less than 30% in micropulse laser. PDT in different concentrations was used. They say 1/3 dose PDT is better than half dose PDT, and half fluence PDT was the least effective. Van Dyke et al. Also showed the superiority of PDT in this, as I previously mentioned, and they also showed that the retinal sensitivity also improved. So treatment in CSR patterns, if you just look at this flow chart, in a patient who lands up with an acute CSCR in your clinical practice, the best treatment would be an observation for the initial period of 3 to 4 months, following which, when the patient is re-examined on an OCT, if the fluid is present, we do an FFA, ICG, and also an OCTA to look for an evidence of any leak. If the leak is present, that leak is treated with PDT. If it is a foveal leak, and if it is a peripheral leak, you can do a focal laser. If in case following this treatment again there is a persistence of fluid, the same protocol is followed, and if on an OCTA there is the presence of a network, probably a role of anti-VEGFs is there. Mineralocorticoid receptor antagonists, although have been much favored in the recent past, but they say they only provide complete resolution in only about 2/3 of patients. Eplerenone and spironolactone are said to be almost equally effective, although eplerenone is more sensitive, more specific for the receptor, whereas spironolactone has a 40 times more potency towards the receptor. But eplerenone is preferred due to a favorable safety profile, although both of them have a similar problem with elevation of potassium levels. And the recurrences post-spironolactone are more likely than after half-dose PDT. And the only positive thing which was seen with the use of spironolactone was the reduction in the thickness of the choroid when the patient was on treatment. The recently released VC trial in late December 2020 and early 21, it categorically stated that mineralocorticoid receptors are no better than a placebo, and clinicians should avoid using these. And in chronic CSIR, the treatment is no different. Again, you have to start off directly with an FFA, ICG, and an OCTA, and based on that, you have to treat accordingly. Laser photocoagulation, when the CSCR is complicated by subretinal macular neovascularization, the incidence was seen to be around 2 to 18%. And this most important thing is that it's a sub-RPE leak, and due to a PCN, it can mimic even an uncomplicated CSCR. So OCTA is mandatory in this subset of patients. So the take-home message for treatment of patients with CSCR is an acute CSCR, initial observation, followed by re-evaluation after a period of 3 to 4 months. In chronic CSCR, subjecting the patient to angiography, OCT, and OCTA. And in chronic CSCR with PCN, keeping in mind the evidence of half-fluence PDT along with a combination therapy with anti-VEGF or a monotherapy can be considered. Thank you.
Thank you, Jyoti. Jyoti, in a CSR which has developed into a CNVM, What would be a line of approach? What would be the preferred line of approach?
Preferred line of approach, according to the Everest trial, would be a combination therapy of half-fluence PDT along with an anti-VEGF. But usually in the given scenario right now, PDT is not very easily available in India. So probably starting off with a monotherapy and probably adding in some level of sub-threshold micropulse laser can be given to the patient.
Can I ask one doubt?
Yes, sir.
Yeah, from the audience.
Yes, sir.
Same thing just now what Dr. Thomas also asked.
Yes,
Because you have mentioned that treatment modalities. But for persistent CSR, as of now, since PDT dye is not available, so what can we actually do for the patient?
Sir, although VC trial has categorically stated that we do not need to and we should not be using eplerenone or spironolactone, but eplerenone, some patients do exceptionally well, but it's a very variable response. So it is not a response which is going to be reproducible in every patient. So that is one trial which can be given. Micropulse laser, subthreshold micropulse laser has the benefit of low cost and the possibility of a repeatability at 3 months if it does not respond favorably. So that can be repeated without any additional permanent damage to the RP in such a case.
We have a couple of patients who we have done all this, even micropulse,
Yes, sir.
repeated, but still it's persisting.
Yes, sir. You are very
So,
correct on that. Unfortunately, it's a very tiring disease. It doesn't go very easy. Had the PDT been there, it would have dried off very easy.
Yeah.
But PDT, unfortunately, at the present moment, is not easily available to us.
So as of now,
Nothing much. Probably micropulse subthreshold laser is the only option which is the least damaging, potentially repeatable, and most easy on the pocket to the patient at least.
Thank you.
But I will be extremely controversial to what I told. The recent paper published in IJO says that in those persistent, not respond to anything, intravitreal dexamethasone might work. It's not my take, I'm only quoting a paper.
Thank you, sir.
Thank you, Jyoti. Please